Today we'll be discussing dermatology recall questions. I'm sure you did your exam well, and so here I'll be discussing the questions which you have told us. So remember, this is a recall session. So the questions here are recall based, and the motive is to get your actual questions from you that you have got in the exam. Now, there are a lot of modifications which students have told me, and I have incorporated them here. And but in case there are any other modifications in the questions or in the options, you're most welcome to get back to us. You can drop a message in the app, or you can put it in the Facebook group also. Remember, whatever answers I'll be giving you is based on what questions and options I have. They may not be the exact question, they may not be the exact option. So I would request, don't mark yourself based on this discussion here. Okay, so let's keep it light and simple. So this was one question. A 50-year-old male presented with history of HIV and some lesions on the palate, and you had to identify the disease. So important thing here is HIV, and this figure, something similar must have been given to you. Now what do you see here? You see a very corrugated vascular appearance here. So you know that this is probably a vascular tumor. So if it is an HIV positive patient who has a vascular tumor, the most likely diagnosis would be Kaposi sarcoma. Now, in HIV individuals, remember, Kaposi sarcoma is a very, very common tumor, very, very common vascular tumor. In fact, seen in 30% of individuals who are HIV positive and are not on antiretroviral therapy. This is basically a spindle cell vascular evasion that is there, and the virus which is responsible is human herpes virus. So it gives rise to vascular tumors which appear as red or purplish nodules or plaques, which are usually present on the skin but can be present on internal organs and can be present in the mucosal surfaces also, and they can ulcerate and they can be painful. Let's look at the other options which they have given. SCC, BCC, these are skin cancers which we do not usually see on the mucosa, and they are not painful. One, BCC is very characteristically seen on the medial canthus of the eye, on the lateral part of the nose. SCC is seen usually in the sun exposed part, and HCC is hepatocellular carcinoma. I don't think so. That would have been the option. But whatever have been, if Kaposi sarcoma was given to you, then that would become my answer here. Coming to the next question, obese female presenting with acne on face, and even after taking medicine, her acne is not getting better. So identify the cause. Now, few of you told me that the medications that have been given were mentioned, that they were given antibiotics and isotretinoin, and patient was not getting better. So what are they pointing towards it? And probably you were also given an image showing acne, and probably you were also given an image where you had acne, and some students said that probably there was hirsutism also present. So remember, acne has variants. And one of the important variants that you know of is called as hormonal acne. Hormonal acne, which is seen in what individuals? In individuals who are obese, in individuals who have PCOS, IR, Saha syndrome, any of the reasons which can lead to hyperandrogenism. All this can lead to hyperandrogenism. PCOS, IR, Saha, hair and syndrome. So all of this can lead to hormonal acne. What do I mean by hormonal acne? That there is increased androgen production. Increase in androgen production, which can lead to acne being resistant to treatment with antibiotics and retinoids. Why? Because there is increased androgen. Till you don't treat that, the patient will not get better. There can be signs which can be seen like hirsutism, FPHL, seborrhea, all these can be present. So there is an obese female who's not responding, so probably she has hormonal acne. And as I told you, hormonal acne is because of hyperandrogenism. Few students told me that the option hyperandrogenism was there, and so that should be marked as an answer. If PCOS was there in the option, you can mark PCOS also. And I was told that both of them were not there in the option. It was either hyperandrogenism or PCOS. So either of them you can mark as an option. Can it be due to change in her diet? Not really. Change in diet can lead to little flare of acne, but they would not lead to a non-responding acne. Can it be due to resistance of antibiotic? Not really. Again, antibiotic resistance, though known in acne, but is not one of the major causes of non-response to medicine. So non-response will happen only if you're missing out an underlying hormonal cause, most common being hyperandrogenism. The next question was, a 35-year-old lady presents to you with a history of hair dye application, presents with the following allergic reaction, and probably an image was given to you where there was diffuse swelling of the face. So, hair dye application in a lady showing swelling of the face is a contact allergic reaction that they are showing to you, and they are asking you what is the allergen here. Remember, you have learnt about allergens. So, hair dye, what allergen is present? It is paraphenylene diamine or PPD. Paraphenylamine, phenyl diamine. Paraphenyl diamine. Or PPT. There was also option of ask history of drug intake. See, drugs can also cause contact allergic dermatitis. But if they have given you a history of hair dye and they have given you a swollen face, this is hair dye dermatitis, and the causative allergen will be paraphenylene diamine, right? So, or PPD, right? So, again, a very straightforward question, I believe. The next question was again very straightforward. A patient with diarrhea, dermatitis, and dementia. Which nutrition deficiency causes it? So, diarrhea, dermatitis, dementia is my 3Ds. Where do I see 3Ds? In pellagra. What is pellagra caused by? Pellagra is caused by deficiency of niacin or nicotinamide. So, wherever they give you this history of diarrhea, dementia, dermatitis, remember your 3Ds. It is pellagra, and pellagra is caused by deficiency of a vitamin, which is niacin or nicotinamide. Okay, whatever options were given, it doesn't matter. If niacin or nicotinamide was given, you can mark directly that as an answer. They like last year, they had given this question. They're very fond of this pellagra, because last year I remember there was a question where they had given maize eater who has some symptoms, or there was a question that a patient with pellagra, what other features will he have. So dermatitis was given in the image, and you had to answer diarrhea and dementia. So it's a very the examiners are really fond of pellagra, and pellagra is caused by niacin or nicotinamide deficiency. So again, a very clear cut question. What is the long term complication of this condition? So, what is this condition? I'm not saying that you must have got the exact image, but something similar to like this. So, you must have got an unilateral or one sided hyperpigmented plaque with lot of hypertrichosis in a child. What is it? This is congenital melanocytic nevi. Congenital melanocytic nevi, and we know that when the congenital melanocytic nevi is giant, when there is presence of satellite lesions here, then it acts as a precursor lesion for malignant melanoma. So, if you have a patient who has a giant congenital melanocytic nevi or presence of satellite lesion, you have to do annual monitoring of the patient to look for development of malignant melanoma. So, long term complication is malignant melanoma. These eye changes are not usually a feature of CMN or congenital melanocytic nevi. I'm not sure whether the image that was given was near the eye or not. Even if it was near the eye, still there are no ocular complications per se that we see with giant CMN. Some students said that probably a trunk image was given. If that was given, then there is no confusion. I'm sure you must have understood that it should be malignant melanoma. So, malignant melanoma has precursor lesions, as I told you. So, atypical nevi, dysplastic nevi, CMN, and junctional common nevi. These are the precursors in which you keep monitoring and think of long term development of malignant melanoma. Clear? The next question was something like this: a female of reproductive age group has a painless ulcer in the perineum associated with painless swelling in the groin or a painless lymph node. What is it? Again, so straightforward: painless ulcer, painless lymph node. I'm not sure about the wordings of the question, but even if it was a little bit different, they had asked you the cause of painless ulcer with painless lymph node, and you know that this is just one condition, which is syphilis, which causes painless ulcer with painless lymph node. Painless ulcer, we discussed, can also be caused by donovenosis, but can donovenosis cause lymph node? No. So granulonoma inguinale or donovenosis causes painless ulcer. It's briefly granulomatous ulcer, but it's very easy to bleed. Plus, there are no lymph node here. What we see are actually pseudobubo. Chancroid, on the other hand, will always lead to painful ulcers. Herpes would also lead to painful ulcers. LGV, you do not see an ulcer. Ulcer is transient, right? And there is suppurative lymphadenopathy. It is painful. So, painless ulcer with painless lymph node is syphilis. Neisseria gonorrhea, you all know, causes urethral or cervical discharge. Okay, so whatever be the question, painless ulcer, painless lymph node, syphilis would be the answer here. Okay, this was a little confusing. Wife of a truck driver with multiple sexual partner presented with. So the first line tells me that they're dealing with STD for sure. Presents with vaginal discharge, and on examination you see cervical erosions. Which STD kit you will give to this patient? Now here I'm sure you must have been confused about whether I should be giving a green kit, which is there for vaginal discharge, or I should be giving a genital ulcer kit, which is syphilis allergic to penicillin or herpetic. So please don't get confused. Why? Because what are the common causes of vaginal discharge? Candida, trichomoniasis, and bacterial vaginosis. Bacterial vaginosis we know is not an STD. So in vaginal discharge we are thinking of candida and trichomoniasis. So remember, trichomoniasis can lead to cervical erosions, or strawberry cervix as we call it. So it can lead to cervical erosions, and so here I will give the kit for vaginal discharge only, which is my green kit. What could confuse this picture? Now remember, herpes sometimes can present with discharge and cervical erosions, but there on examination you will see cervical discharge also. You will not see vaginal discharge. Plus, if there are erosions, they will usually give you vaginal erosions also. So, because I don't think so, examiner would try to figure out whether you know that herpes can cause cervical erosions in such form. So, if there was no confusion here, vaginal discharge, which on examination showed cervical erosions, they are probably talking about trichomoniasis, and so you will give green kit to the patient, right? Okay. Now, this is a little confusing question, and I do not have inputs from the students regarding this. So, I would want you to share if there were any other options or any other information in on this question. So, here I have a male, an HIV positive patient with following lesions. Now, what do I see here? I see lot of umbilicated lesions here. So, the first thing that I will think of is disseminated molluscum contagiosum, right? But remember, students, even cryptococcus causes umbilicated lesions. So, both molluscum and cryptococcus can cause umbilicated lesions. And cryptococcus is an infection which you can see in immunocompromised. So, you see it very commonly in HIV patient. So, what option will you mark? If this was the particular image which was given, I am seeing an ulcerated lesion here. I am seeing an ulcerated lesion here. If there is ulceration, my answer will become cryptococcus here. Because when we have an HIV positive patient, there can be umbilicated lesion. We can think of molluscum, can think of cryptococcus. But the differentiating feature between cryptococcus and molluscum is that cryptococcus shows ulcerations, whereas molluscum does not show any ulceration. So, this is really important. So, again, I'll emphasize I'm not sure whether this was the exact image or exact question that was given to you. But if this was the question, if this was the image or any image which was showing umbilicated lesions with ulceration, then cryptococcus would be the answer. If there was no ulceration, you could just say umbilicated lesion, you can mark molluscum contagiosum. So I would request you to send me your questions, options, or if you think some figure was different in and I can help you out with the exact answer. With this question, with this image, cryptococcus would be my preferred answer because I can see ulceration here, right? So these were the dermatology questions that we got. If there were any other questions, you're most welcome to share with us. Thank you and take care and all the best for your results.